I'm Dr. Seth Rosenzweig, board-certified orthopedic surgeon. These videos on my YouTube channel will help take the mystery out of your orthopedic injury or sports-related injury as we go from the exam room to the operating room through your recovery. So Garrett has what we call a biceps slap tear, where his biceps tendon runs into the shoulder and there's a little detachment in there. So anytime he does overhead activities, it bothers him. Also has a small rotator cuff tear, so we'll see how bad that is when we actually get in there. But the other thing with Garrett is he's got what we call posterior laxity, meaning I'm dislocating his shoulder and I get a crunch, which tells me that there may be a little labral tear. So I don't know if you can appreciate in, out, in, just like that. So we'll test that also. We'll do the subpec for the biceps right here and possibly a rotator cuff repair versus debridement. This is Garrett's shoulder arthroscopy. What we're initially seeing is the front of his shoulder to the bottom of the screes, his glenoid, the socket, above is the ball, the humerus. That's a shaving tool I have in the front of his shoulder. I'm just lightly debriding what we call the labrum. It looks like a speed bump right there in front of the socket. That is his subscapularis tendon below the shaver, and that is his biceps tendon above. You can see I'm pulling the biceps further into the shoulder to show that redness, which is the inflammation. That's his rotator cuff directly above us, and I'm starting to lightly debride some of the fibrous sick tissue. And you see I'm not actually pushing the shaver into the rotator cuff. I'm letting the tissue come to the shaver. It has a suction device, so anything non-viable will be pulled into the shaver, and I won't actually debride the good tissue. We can tell that he has a high-grade partial thickness tear of his supraspinatus. That's a rotator cuff tendon. I'm lightly debriding it. I just want to take the sick tissue, not the good tissue. And at this point, I'm just letting my shaver pull with its suction device anything non-viable. Now I'm coming in with what we call a cautery device, and I use this also to dissect. I'm using a very light coagulation function to try and get rid of some of this extra tissue you see hanging down. All of these things act as blocks mechanically within the joint, such as a pebble getting caught in the gear. So I want to try and get rid of all these loose pieces of tissue so they don't get caught between his ball and socket. And so the question is once I've done getting rid of this bad tissue, does he have a hole big enough that's going to need to be repaired? And it's looking like we probably are going to have a higher grade enough tear where we probably do need to put a stitch in it. So I'm finishing the debridement, and I was really here to do what we call a slap tear, which is that right there. I'm pulling the biceps over, and you can see it detaches from the top of the glenoid. It's pulling that bumper off. So he's been dealing with this for a while. So the idea is that we'll go ahead and get the biceps off of that labrum so it's not pulling on it anymore. And I'll again lightly debride it. I'm not going to put any stitches in the labrum there because he's not a baseball player or overhead athlete. So it's been found that it's not quite necessary in just everyday guys. So again, with my cautery device, debriding any light tissue that's not viable. I don't want to get the good tissue. Now I've made the decision I'm going to repair this rotator cuff tear at the end of the case. So you see me coming in with a needle here, and we use these needles to localize in arthroscopy before we actually make holes on the outside. So I know that I want to get a stitch through the rotator cuff cable, which is, I'm about to poke through that thicker tissue there. So I have one bite there, and the goal is I'm going to throw another penetrator through that cable, and I'm going to pass a stitch to myself so that we can control this tendon and repair it at the end of the case. You can see it's very much like one of the video games at the arcade. I'm handing off to myself a piece of string, and then you're going to see ultimately I'm going to pull both ends out, and now we've got control of that rotator cuff tendon. I'm going to use that purple stitch to actually shuttle a stronger stitch through. So once I've done that, I'm now putting a cannula in his shoulder, which is a plastic working device. I use this stick right here called a switching stick, and I'm going to place over it a cannula so that I can pass tools through it to work in just a little bit. So I'm using that stick as a guide, and then I place my cannula over it and we remove the stick. So I'm at the back of the shoulder now. We're looking from the front to the back. And part of Garrett's problem is his ball moves to the front and back of his socket, and it goes over the speed bump. So you can see that he's been doing that in the front, and he also on the table dislocates out the back. So in his case, I don't want to tighten him too much. So you see I'm finding position here. I want to put a couple of holes in the socket so I can sew his tissue into it to tighten the shoulder. So I'm using again a stick to pass my working tools over. I have a drill now. I'm going to drill one socket. This is very low on the glenoid, meaning we're looking down at the bottom of his socket. I'm going to place my first hole very low on the socket, and then I'm going to place just one more. And again, we're in the back of the shoulder. And the goal is I'm going to tighten up the back of his shoulder by sewing the tissue into those holes. Again, Garrett on exam does like to slide out the back in front of his shoulder, more so the back. So that's where we're going to put 2 stitches. And in the front, you're going to see I'm going to drill one hole into that defect there so that we can tighten the tissue there also. So I'm going to bring in my drill guide here in just a second. And you take your time with these drill guides because you really want a good angle. You want to be close to 70 to 90 degrees as far as your angle. And we have a good one there. And I'm just off of the face. So here comes, we're at the front of the shoulder now. And I'm drilling one again. Probably if we were to make this a clock, I'm at the 8 o'clock position. 6 o'clock would be the most farthest inferior point. So this is my passing device. I'm going to grab some of that tissue we just talked about, some of the capsule, some of his inferior glenoid ligament, and some of the labrum. And you're going to see me pass a stitch through it. And we do a lot of shuttling, meaning I'm going to pass a temporary wire, and then I'm going to place a real suture into it to actually pass it. And there goes the suture I'm passing. And this knot I'm going to tie is what we call a cinch loop, meaning that I'm going to bring both tails through the loop to make it more of a cinch. So you see me bringing both the tails, and we're going to look at the front of the shoulder. I'm going to walk down my knot that I've put the 2 tails through the loop. And now I have a very firm handle on this tissue once the knot goes all the way down. And I'm going to actually put that into the hole in an anchor. And you don't actually see me do that in this video. You're about to see the finished product once I've put the anchor in the front and the 2 anchors in the back. So those are 2 anchors in the back. You can see I sewed the sutures into the hole. There's the back, and we've nicely centered. And look how much space I've decreased in the back of the shoulder. Now I just want to lightly debride a little bit more, make sure I haven't missed any loose tissue, make sure I don't need another stitch. Sometimes I'll even do 4 to 5 of them in the back. But in Garrett's case, it looks like we nicely reduced his posterior capsulolabral complex. We've removed any loose debris over where his biceps attached. And now we're going to go and fix that rotator cuff on top of the shoulder. And we've been in the shoulder at this point, but we're about to go on top of it into what we call the subacromial space. Again, lightly debriding some of the non-viable tissue. And we've completed our work within the shoulder. And you can see some of the snapshots from the before, our stitch on top of the subacromial space, bringing over this pasta tear to a lateral anchor, the lateral side of the shoulder. Here's a view from lateral, room with the view, showing us pulling the pasta over. Once again, one more view, and I didn't sew this into bone. I did more of a side to side. And you can tell there's still some roughness there, but we don't over tighten. With these pasta repairs, you have a great chance of doing too much trying to tighten it into the bone, so I've found this is a nice technique. Thank you for watching. Please subscribe to this channel to watch more of my videos. If you have joint pain or a sports-related injury, I'm here to help. I want to help you live your life to its fullest.